Pulmonary function test, it's a group of studies or maneuvers performed using a standardized equipment to assess the lung function, mainly about the lung mechanics, parenchymal function, and cardiopulmonary interactions. Indications of pulmonary function test, it can be diagnostic and prognostic. Diagnostic, to evaluate the symptoms like dyspnea, cough, and to measure the effect of disease on pulmonary function like obstructive or restrictive pattern, to screen individuals at risk of having pulmonary disease like the smokers, individuals in occupation with exposure to injurious substance like asbestosis, to assess the perioperative risk in obese patients, in patients undergoing upper abdominal or thoracic operations, or patients known to have a pulmonary disease, to monitor drug toxicity like adverse drug reaction known to have pulmonary toxicity like bleomycin and amiodarone. In prognosis, to assess the severity of the disease, to assess the therapeutic intervention with bronchodilator therapy, steroid therapy for asthma, interstitial lung disease, to describe the course of disease affecting the lung, like pulmonary interstitial lung disease, neuromuscular disorders, and to monitor adverse reactions. Preoperatively, indications according to the American College of Chest Physician, it is used in lung resection surgeries, history of smoking and dyspnea, cardiac surgery, upper abdominal or lower abdominal surgery, and when the patient is having uncharacterized pulmonary symptoms. The contraindication is there is no absolute contraindication. Relative contraindications are recent MI of less than 1 month, unstable angina, vascular aneurysm of thoracic abdominal or cerebral aneurysm, recent ocular surgery because of the raised intraocular pressure during forced expiration, patient having a pneumothorax and active hemoptysis. Uh, So periop evaluation is done and history examination, chest X-ray showing hyperinflation of the lungs indicates 33% significant risk in pulmonary complications. Pulmonary function test includes bedside pulmonary function test, which tests for the vital capacity and dynamic test, lung mechanics, which tests the statics and dynamic lung volumes, parenchymal function, which includes gaseous exchange, diffusion capacity of the lung, and cardiopulmonary interaction with a 6-minute walk test, oxygen consumption. Split lung function test and 3-leg stool test are used in lung resection surgeries. Bedside function test, it can be done with equipments or without equipments. Without equipment, we have the subraised breath holding test or subraised single breath hold test, which tests the vital capacity. In subraised breath holding test, ask the patient to take a deep breath and hold his breath. If it is more than 25 seconds, then the patient is having a normal cardiopulmonary reserve. If it is about 15 to 25 seconds, there is limited cardiopulmonary reserve. And if it is less than 15 seconds, there is poor reserve. We can measure the tidal volume, vital capacity via this. If the breath holding is about 20 to 25 seconds, that is about 300 ml of vital capacity, and 15 to 20 ml, 20 seconds, about 2500 vital capacity. And if it is about 10 to 15 seconds, then 200 ml vital capacity. Less than 10 to 15 seconds, it is contraindicated for elective surgeries. Sabari's single breath count, ask the patient to take a deep breath and count without expiration. If it is more than 20, then there is a good cardiopulmonary reserve, and less than 10, poor cardiopulmonary reserve. Snyder's match blowing test, it estimates the maximum breathing capacity is the ability to blow a match at 6 inch, that is 15 centimeter, with chin rested and supported, mouth wide open, and no pursing of lips. The nose clip should be attached, and there should be no air movement in the room. The mouth and the match should be at the same level. If the patient is able to blow at 6 inches, then the maximum breathing capacity is about more than 60 liters per minute, and the FEV1 is about more than 16 liters per minute. If it is about 3 inch, then the maximum breathing capacity is about 40 liters per minute. If the patient is able to blow at only 3 inch, then there is an increased risk of pulmonary complication. It brings out it states the ability of the patient to cough and bring out the secretion in post-operative period. It increases the post-op atelectasis. Then we have the cough test. We ask the patient to take a deep breath and cough. We should assess the cough effectiveness, strength, and productivity. If it is an inadequate cough, then the FEV1 should be less than 15 ml per kg. FPC is about less than 20 ml per kg, and peak expiratory flow rate is about less than 200 ml, 200 liters per minute. Then we have the forced expiratory time or step test or auscultation over the trachea. We have to ask the patient to take a deep breath and exhale maximally. A step is kept over the trachea. Normal expiration is about 3 to 5 seconds. If in obstructive lung disease, the expiration is about more than 6 seconds in COPD patient, and in restrictive lung disease, it is about less than 3 seconds. Right peak expiratory flow meter or Debnose whistle. Here it's with the equipment. Here the patient is asked to inhale deeply and exhale maximally. In males, it is about 450 to 700 liters per minute, and in females, about 350 to 500 liters per minute. If it is less than 200 liters per minute, then there is an ineffective cough. With equipment, we have the dial type spirometer, which shows the vital capacity. A mouthpiece is attached, and the patient is asked to blow. In right respirometer, it shows the minute ventilation. By dividing with the respiratory rate, we get the tidal volume. And we have the bedside pulse oximeter, ABG, and respiratory rate to show the lung status of the patient. In lung mechanics, we have static and dynamic lung volumes, static and lung volumes. Static lung volumes, we have 4 volumes and 4 capacities. 4 volumes are the tidal volume, inspiratory reserve volume, expiratory reserve volume, and the residual volume. Tidal volume is the volume of air inspired and expired during normal quiet breathing. It's about 500 ml, that is 8 ml per kg. Inspiratory reserve volume, it's the maximum amount of air that can be inhaled after a normal tidal volume inspiration. Normal is about 3 liters. Expiratory reserve volume is the maximum amount of air that can be exhaled from a resting respiratory level. Normal is about 1.1 liters. And we have the residual volume, is the volume of air remaining in the lungs at the end of maximum expiration. Normal is about 1.2 liters. Air cannot be removed further by forceful expiration. Now we look into the capacities. We have the inspiratory capacity, functional residual capacity, expiratory capacity, and vital capacity. Inspiratory capacity is the maximum amount of air that can be inhaled from the end of a tidal volume. That is the inspiratory reserve volume and tidal volume. Capacity includes 2 or 3 volumes. Inspiratory reserve volume is about 3,500 ml, that is 3.5 liters. Functional residual capacity is the volume of air remaining in the lungs at the end of tidal volume expiration. Functional residual capacity is equal to expiratory reserve volume plus residual volume, that is about 2,500 ml. Functional residual capacity is decreased in the induction of anesthesia and in post-op patient, especially after abdominal surgery. The FRC acts as a reservoir of oxygen, which is increased by reoxygenation and prevents hypoxemia during apnea. It is decreased in pregnancy and neonates, and this determines the speed of induction in inhalational agents. FRC is increased in bronchial asthma, overinflation of lung after thoracotomy, and in emphysema with air trapping. It is due to, it also changes with the position. Vital capacity. Vital capacity is the maximum volume of air that can be expelled from the lungs by a forceful effort following a maximum inspiration. Vital capacity equal to tidal volume plus inspiratory reserve volume plus expiratory reserve volume. It's about 4,600 ml, that is 4.6 liters. The normal values depends upon the height, age, gender, and race. It is increased in persons who exercise and in athletic persons. All the volumes and capacities are 20 to 25% less in females. Some values change in position. Mostly they are decreased in supine position and increase in erect position because of the increased pulmonary blood volume and the tendency of the abdominal contents to push the diaphragm upwards. So normal tidal volume is about 6 to 8 ml per kg. Inspiratory reserve volume is about 1.9 to 3.3 liters. Expiratory reserve volume is about 1.5 liters. Residual volume is about 20 to 25 ml per kg. And the capacity, functional residual capacity It's about 30 to 35 ml per kg. Vital capacity about 60 to 70 ml per kg, and total lung capacity is about 66 liters per minute. These can be measured by the spirometry. Values which cannot be measured by the spirometry are the residual volume and the functional residual capacity, total lung capacity. The residual volume is measured by nitrogen washout method, helium dilution, and body plethysmography. The vital capacities are degrees in position. Now we come into the dynamic test. We have the forced vital capacity maneuver. Ask the patient to take a deep breath and exhale maximally over 6 seconds. We have the volume time graph, flow volume loops, pressure volume loops, and respiratory muscle strength in dynamic maneuvers. Here we look into the FEV1, peak expiratory flow rate, and maximum blowing capacity. FEC is the volume of air exhaled after maximal inspiration. It reflects the flow resistant property of the airway. Normal is about 80 to 120% of the predicted value. If it is about less than is about 70 to 80%, then there is mild obstruction. 50 to 70%, then there is moderate obstruction. And if it is less than 50%, then severe obstruction. FeV1 is the volume of air exhaled in first second. That is the percentage of FeC which can be forcefully expelled as rapidly as possible in 1 second after maximum inspiration. It is used to assess the airway obstruction. Normal is about 80% of FeC in first second. So 60 to 80% indicates mild obstruction, 50 to 59% moderate obstruction, and less than 50% severe obstruction. Tiffany's index, which includes the FeV1 by FeC, normal is about more than 0.8. It is normal. It is used to differentiate between obstructive and restrictive lung disease. In obstructive lung disease, the FeV1 is decreased and the FRC is near normal. So FeV1 by FRC ratio is decreased, less than 0.8. In restrictive lung disease, the FeV1 is decreased and the FVC is also decreased. FRC is also decreased. So FeV1 by FVC is normal, but the total lung volume is totally reduced. Maximum breathing capacity. Here the patients are asked to inhale and exhale maximally, done over 15 seconds, which is exponentiated over 1 minute. In males, it is about 140 to 180 liters per minute, and females is about 80 to 120 liters per minute. Maximum breathing capacity is generated as FeV1 into 35, and peak expiratory flow rate is the maximum flow rate achieved during FVC maneuver after full inspiration with maximal expiration. It can also be measured with Bright's peak flow meter. Peak expiratory flow rate is equal to 3 to 4 times the maximum breathing capacity. And maximum voluntary ventilation is the total volume of air moved in and out of the lungs over 1 minute. It is about 100 to 120 liters per minute. Patient breathes in and out as rapidly and fully as possible over 12 to 15 seconds. Maximum voluntary ventilation is equal to FVC into respiratory rate. Now we come into flow volume loops. Is a graphic analysis of flow at various lung volumes. Here we look into the peak expiratory flow rate, maximum mid expiratory flow rate. The peak flow expiratory flow is it measures how much air can be expired from the lungs. It divides the expiratory flow into 4 quarters: FEF 25, 50%, and 75%. FEF forced expiratory flow 25 to 75% is effort independent. If it is more than 60% of the predicted value, it is normal. 40 to 60% mild obstruction, 20 to 40% moderate obstruction, and less than 10% severe obstruction. Is the earliest and sensitive indicator of small airway disease. The inspiration is effort dependent. The inspiration is also effort dependent. We look into the bronchodilator effect with pre and post bronchodilator. If there is a more than 12% change in the FEV1 and 200 ml change in FEV1, then there is a good reversibility with bronchodilators. We can, using this flow volume loop, we can We can categorize obstruction as extrathoracic, intrathoracic, variable obstructions. It is useful in the diagnosis of lung disease. Now coming to the respiratory muscle strength, all the dynamic tests needs good muscle power. Negative or positive pressures are generated on an anaerobic gauge with a valve during inspiration and expiration respectively. It is useful in patients with neuromuscular disorders and is useful in weaning from ventilation. If the maximum static pressure in inspiration is normally about minus 125 centimeter of water, if it is less than minus 25 centimeter water, then the patients have an inability to take deep breaths. If the maximum expiratory static pressure is about normal is about 200 centimeter of water, if there is a reduction about 40 centimeter of water, then the patient has an inability to cough. The respiratory muscle weakness is the prime cause of hypercapnic respiratory failure. Now coming to airway resistance. Airway resistance is the difference between the atmospheric pressure and alveolar pressure. In normally, there is a low resistance at high lung volumes. That is total lung capacity, there is a low resistance, and in residual volume, there is high resistance. The methods is used to measure the airway resistance are whole body plethysmography, forced oscillation method, pressure flow method, interrupter method. The spirometries have a certain limitations and criteria. The limitations include the accuracy of the test depends upon the well-trained technician as well as the patient's cooperation. So we should educate the patient prior to the procedures. The requirements for good PFT, that should be a lack of artifacts induced by coughing, glottic closure, or equipment problems. There should be no leak. There should be satisfactory start to the test without hesitation, and satisfactory exhalation with 6 seconds of smooth continuous exhalation. Criteria for reproducibility includes large forced vital capacity within 0.2 liters, that is 200 ml of next largest forced vital capacity. 3 efforts should be made. Difference between the 2 efforts should be less than 200 ml, and forced expiratory volume in 1 second, that also should be less than 200 ml between the 2 FEV1. Up to 8 efforts can be made to meet the acceptability and reproducibility criteria. Beyond this, there may be fatigue. So the patient is asked to take this and the test is again repeated. Parenchymal function. In parenchymal function, we have the gaseous exchange and diffusion lung capacity. Gaseous exchange can be noted by the ABG, that is alveolar blood equations, blood gas analysis. We have the alveolar PaO2 and arterial PaO2. Normal is about 8 to 25 mm of mercury. It is used to estimate the lung function. Value of less than 60 mm of mercury is significant. And PaCO2, pH, and bicarb, it also denotes the ventilatory and metabolic property of the lung. Diffusion capacity of the lung, that is the transfer factor of the lung. It measures the gas exchange between the inhaled gas in the alveoli and the capillaries. Here, the patients are asked to inhale the test gas, which contains 10% of helium, 0.3% carbon monoxide, 21% oxygen, and 68% of nitrogen. The patient is asked to take a deep breath, single breath, and inhale the test gas to total lung capacity and hold the breath for 10 seconds. Then the patient is asked to expire. We measure the diffusion lung capacity via this, and the normal is about 20 to 30 ml per minute of mercury. Here the carbon monoxide is used because it has a high affinity to hemoglobin and has a normal concentration of the pulmonary circulation is 0. So factors affecting the diffuse lung capacity, it is decrease in anemia, emphysema, pulmonary embolism, and lung resection, post lung resection because of the decreased surface area and by reducing the capillary blood volume. It is also decreased in pulmonary edema and fibrosis due to the increased alveolar thickness, and it is increased in patients with polycythemia, increased pulmonary blood flow, supine position when there is a left to right shunt, and obese patient. Cardiopulmonary reserve. Here, the cardiopulmonary reserve is checked by the oxygen consumption. At rest, it is about 5 ml per kg per minute, that is 250 ml per minute. At exercise, the oxygen consumption increase up to 20 ml per kg per minute. It is tested by a stair climbing test. One flight of stairs, that is 20 steps, which is about 6-inch high steps. The patient is asked to climb at his own pace without stopping. If the patient is able to climb one flight, then the oxygen consumption is less than 10 ml per kg per minute. 2 flight, it is about 12 ml per kg per minute, and 5 flight of stairs, it is about 20 ml per kg per minute. Functional walking test. Here, the patient is asked to walk between two shuttles of about 10 meter. Then, and the saturation is also noted. If the patient's saturation falls below less than 4% and not able to walk more than 250 meters, then the oxygen consumption is less than 10 ml per kg per minute. If the patient walks about 350 meters, it is about 11 ml per kg per minute. In 6 minutes walk test, the distance traveled in 6 meters divided by 30 gives the oxygen consumption. If the patient walks about 6 meters, then 600 divided by 30, that is 15 ml per kg per minute. It indicates a good cardiopulmonary reserve. Cardiopulmonary exercise testing is also done to look into the anaerobic threshold, maximum oxygen utilization, and maximum heart rate, oxygen saturation, etc. Split lung function test and three-leg stool tests are used to predict the post-op lung function in pneumonectomy or lung resection surgery patients. Now coming into the interpretation of spirometry in obstructive and restrictive lung disease. Coming to obstructive lung disease, here the vital capacity is normal or decreased, total lung capacity is increased, residual volume is increased, and FEV1 by FVC is decreased. So maximum breathing capacity and maximum mid-expiratory flow rate is decreased. In expiratory restrictive lung disease, the vital capacity is also decreased, total lung capacity decreased, residual volume is decreased, but FEV1 by FVC is normal or increased. So maximum breathing capacity and maximum expiratory flow rate is also increased or normal. So when you look into a pulmonary function test, we see into the peak expiratory flow rate. We look into the FEV1 by FVC. If it is more than or equal to the lower limit of normal, then we look into total lung capacity. If it is less, then it becomes under restrictive lung disease. Then we look into the deficient lung capacity. If it is more than the lower limit of normal, then they have a chest wall deformity or neuromuscular disease. If the deficient lung is less than the lower limit of normal, then they have an interstitial lung disease. If the FE1 is by FVC is more than or equal to lower limit of normal, then we look into the FVC. If it is also more than the lower limit, then deficient lung capacity is look into. We look into if it is normal, then the patient is normal. If it is less than the lower limit, then the patient is having pulmonary hypertension, anemia, carboxyhemoglobin. If the FEV1 by FVC is less than the lower limit by normal, then they look into the FVC and total lung capacity. If it is lower, then they have obstruction. If it is normal, then they have obstruction, and it is lower, then they have a mixed disease. Thank you, sir.
Welcome. Very good. It was a very elaborate and fantastic presentation. You covered all the possible function tests. But I just want to ask you one question. Do you do these lung function tests routinely for all patients with respiratory diseases?
No, sir.
How many times have you seen a patient being referred to pulmonary function test in your pre-anesthetic assessment so far in your career?
When they're having scoliosis procedure, they usually prefer asking PFT, sir. And known COPD patients, PFT.
Very severe COPD patients of long-standing history, when they come for a surgery, we may ask for them. What is the main purpose of asking for a pulmonary function test in a patient with a long history of COPD?
Whether they need maintenance therapy of bronchodilator or bronchodilator reversibility, and their FEV1 by FVC ratio.
how severe the disease is, number one. Two,
Yes.
whether which bronchodilator produces the best result in them, and whether it will be useful in case if they develop any acute obstruction intraoperatively. Okay, that is the reason why we want this pulmonary function test. Otherwise, what is the major indication for pulmonary function test? Which surgery requires definitely a pulmonary function
Pneumonectomy, sir.
test? Lung surgery. Okay, when you want to resect a part of the lung or a total lung on the side, lobectomy or pneumonectomy, then we do these pulmonary function tests in them to assess whether what is the reason for doing the pulmonary function test before lung resection surgery.
To see cardiopulmonary status are the three legs.
Cardiopulmonary reserve. Okay.
The parenchymal function, and
Contribution of the lung to the total lung function.
they need
Whether
any ventilation.
tolerability.
Well, what is the post-op requirement of the patient? Because after you do a lobectomy or a pneumonectomy, you need to know whether, first of all, the patient can survive with the other existing lung, especially if you are going to remove a totally diseased lung on one side. You must know preoperatively itself whether the patient can survive with the other side lung alone. Then second reason is when you do resect the lung, whether the patient will require any post-op ventilatory support for a few days or hours till he can survive on his existing lung. The third reason is if the normal lung is already well compensating, whether you can extubate the patient immediately after surgery or not. These are the three reasons why you want to do that. One, if the normal lung is already well compensating for the diseased lung, you can plan for extubation on the table. Otherwise, you may have to support the ventilation for a few hours or days. Third is, you must avoid doing the surgery because patient cannot survive with the existing lung. So these are the three reasons why you want to do the pulmonary function test. Okay? And for that, nowadays, we were earlier doing only this parenchymal test and mechanics of the lung test. But now with the advent of cardiopulmonary exercise testing, we get more values like anaerobic threshold, maximum capacity of oxygen utilization, delivery, all these things are given. So you find in every conference when you go, there is a workshop on cardiopulmonary exercise testing. Okay? So people are now going in for that. But what is the restriction on usage of cardiopulmonary exercise testing, the so-called CPH? Anything elaborate is always costly. So you have to have a proper setup for that. You must train personnel, you must have the equipment. Okay? So with all that, this is not becoming a routine thing in the armamentarium of pre-op assessment. But days are not far. Between every hospital may have a cardiopulmonary exercise lab, which is be more useful to do the test in deserving cases and take a proper decision. So you have done a very excellent job by detailing right from starting the bedside function test to going on to the test done with the equipment.